and to make sure they understand what you are saying. Use language appropriate to the patient's level of understanding in a language of their fluency. And again, this could be a problem actually, especially for some of the practitioners in Saudi Arabia are not Arabic speaking, and we have like many Arabic speaking or these Saudi patients who may not be fluent in English. So here comes could be a problem. However, by any means, you should make sure that your patient understands. Whether they speak Arabic, let them have the whole information in Arabic, in a language that not even the traditional classical Arabic. If they get just simple people who just they speak the street language, if you like. Pause, observe the patient for their reaction. This is very important actually. Again and again, I would say that ethics is hugely, highly affiliated and related to the to communication. It's about your communication skills, to what extent you are dealing with your patients as humans, not as just sick bodies. So the second thing is the comprehension. You should invite the patient to share his fears or her fears and concerns, hopes and expectations. It's very important, many of the times, I would say most of the times, that when the patients refuse treatment or say, no, I will not go for this, this is because they have their own fear, they have their own concern, they have their own bad experience. A relative of them died of the same treatment. They have, like her mother had the same problem like 10 years ago and she died after this. So more or less they have their own fears. The point is you should spare some time to talk to your patients and to invite them to talk openly about themselves. Show empathy and compassion. I know some doctors find difficulty in that because somehow doctors get cold-blooded and they just don't care very much about how their patients feel. We should not do this. We are again dealing with humans. Explanation should be given clearly and simply, and questions asked to assess understanding. You should be asking your patient whether they understood or not. Written instructions or printed materials should be provided. It's sometimes helpful to give a brochure about the disease, a brochure about the intervention, or something to read if the patient, can read. If not, maybe a CD with a movie or something could be helpful just to provide them with the needed information. Talking about the voluntariness, as we said, it's to have freedom from undue influence. Undue influence could be physical. Sometimes, I didn't see that, at least not in the last 10 years. But sometimes the co-patients or the family is bringing, the teenager or something, like they physically restraining him, or I won't say in cuffs, but at least they're not free to do what they want really. Coercion involves the use of explicit or implicit threat. For instance, if a doctor tells his patient, okay, I'm the doctor and I think you should go for surgery. If you don't want to go for surgery, then don't ask me about whether I will come to you. I'm not sure if I can come to you anymore, or I'm not sure if I can follow you up or whatever. This is a threat. Although it's implicit, but it is a threat. It's undue influence, as if you are pushing your patient towards a given choice. Omission of information, attempt to induce the patient to accept a treatment. Sometimes you just hide some information, you don't tell the whole truth, so that the patient would be, I would say, deceived and take your option. Undue financial payment, as I said, that sometimes I can't imagine a situation where doctors pay for patients to be treated. However, in some countries, doctors or medical students sometimes pay for these patients to let them examine them. And this could be one way of perhaps an undue financial payment. Undue influence, like emotional, as we said, or community pressure, like as I mentioned, like a husband, somehow the presence of the husband affected the way the wife would take her decision. Misconception of facts. Sometimes people are not clear about. I'll give an example. One of the most problems that many countries face is about the misconceptions about vaccination, for instance. They believe that vaccination is kind of a Western conspiracy that would lead to infertility of the next generations, etc. So this could affect this could affect the decision capacity. The documentation of the consent, it's very important actually. It's very important that the documentation of the consent That is to say, we need to document that this consent has been taken. Okay, and there are actually two examples of consent, or ways of expressing consent or saying consent. This sometimes is expressed. That is to say, a patient says, "Okay, doctor, yes, I want this treatment, or I want this surgery," and they write it down and sign the consent. The other, sometimes it's an implied consent. I'll give an example. Sometimes patients express that they accept the intervention, okay, without saying so. I give an example. If you ask a patient, or tell your patient, "Okay, excuse me, ma'am, I want to, may I examine your blood pressure?" Or she is in the lab, or he is in the lab, and the technician says, "Excuse me, sir, I need to take 5 cc of your blood." And if the patient simply just extends her forearm, this is an implied consent. That this means that this patient is accepting that this amount of blood be taken from his blood. So basically, we need, but either way, we need to document the consent, and the rule is it should be written and a copy found in the medical record or the medical file of the patient. Okay. Sometimes patients may not be able to give a consent. For instance, in case of emergency, not all emergencies indeed, but sometimes the patients are not competent, they are not fully conscious to give a fully informed consent. So basically, what we do is either this patient is accompanied by someone who is competent to give a decision, like for instance, his mother, his father, etc., to decide on his behalf, or otherwise, if he's not accompanied by anyone, so the present physicians take what is the consent on his behalf to provide him with what's in his or her best interest. Children and perhaps adolescents also, it varies a lot from country to country about whether children should be given the right to consent or not. Alcohol substance abuse, or someone coming to you, as I said, drunk or under the effect of a certain drug. So basically, they may not be able to provide you with a consent. Mentally disabled, or actually more widely, patients with some psychological problems that could affect their capacity. And we gave an example of those with uncontrolled severe depression. So regarding the mental patients cannot consent to treatment, research, or sterilization because of their intellectual incompetence. However, they can be admitted, detained, and treated voluntarily or involuntarily for their own benefit in emergencies for purposes of assessment, if they are, for instance, a danger to themselves or to the community. So basically, it depends on how severe the case is, how severe the condition of the person is. For instance, they could be harmful to themselves if they have suicidal patients, or they have suicidal tendencies, or to their communities if they have kind of criminal intentions. In the unconscious, we said that for patients in coma, proxy consent by family members can be restored. If no family members are available, the physician does what he, as a professional, thinks in the best interest of the patient, and then seek informed consent for further interventions. Regarding the labor and delivery are emergencies that require immediate decisions, but the woman may not be competent, and proxies are used. Usually, if she comes with her mother or the husband, usually are those, because sometimes she is either unconscious, she is bleeding, she is so much under stress. And it's a very common thing. From your practice in obstetrics, it's almost all women in delivery ask for cesarean section, for example, because they are in severe pain and they want this pain to end as soon as possible. And we cannot take their, as this is a consent or as a need. If it's not, no need, actually, I mean, clinically speaking, to go for section, she should not be sectioned. So, general challenges for patient-physician communication. For you as a doctor, you should be aware of these challenges so that to tackle them and to know how to deal with them. First, the time constraints. Usually, clinicians, the clinicians, are so busy, and you find it difficult for your time. The language differences. Sometimes the doctors are not Arabic speaking, or vice versa. Mismatch of agendas. There are different priorities, different way of thinking between the doctors and the patients. Lack of teamwork. It's very important actually to develop good relations with the whole team, because simply if you do, many times the frontliners are the nurses. If you're not talking enough, or you're not communicating well with the rest of the health team, especially the social health worker, all the nurses, or whoever else in the team, then basically this would affect the ability of the patient to be communicated and to communicate, and consequently to give a consent. Okay. So the patients, how the patients take the decisions. They are either they have their own values, their own priorities, or on cultural basis, okay, or religious beliefs. The control, desire for information and control personality, the coping style, roles, spouse, parent, child, or provider. All of these factors are the factors which affect the patient's decision. Either his culture, his beliefs, his religious beliefs, the family members, or even the provider himself. Degree of dependence upon and trust in the professional. That is to say, if sometimes if the patients are so helpless, are so hopeless, are so dependent on the provider, so sometimes they try to feel independent, to feel the power, to feel that they are in charge of their bodies. While the professional usually take their decisions based on their education, their knowledge, their experience, their communication style, their values and priorities, their demographic profile, that's to say their gender or their sex, their age, etc. So all of these are the way the patients and the doctors take the decision, and we should consider that when we are communicating with our patients. There are indeed some difficulties, including the use of technical language, uncertainties to all medical information, because simply doctors are not 100% sure that this will happen. It's all about possibilities. So basically, you're not 100% sure that this will cure or this will kill. Worried about harming or alarming the patient, hurried and pressed by multiple duties, especially for the busy clinicians. Okay, basically here I would say it in a briefly. It's some fiqhi or Islamic points that should be considered. It's about the permission. Any person, any other person had the right to give permission before being approached by the physician. And the rule is that you should not approach anyone for something related to his health or body without prior permission. Our take-home message is informed consent is a process of communication. It's not a document to be signed, okay, between the clinician and the patient or patient representative, patient family, and it's not simply a matter of obtaining patient signature on an informed consent. Thank you.